So a patient walks into a clinic, right? And they're asking for a cosmetic procedure.
Yeah.
The surgeon takes out a scalpel to fix a physical problem. But for well, a hidden percentage of those patients, and sometimes this is nearly 1 in 5, the physical problem they're pointing at just doesn't actually exist.
Yeah, the defect is entirely in their mind,
Right.
which is, it's the absolute definition of diagnostic muddy waters.
Hmm.
I mean, we are trying to use a physical solution to treat what is basically an invisible psychological condition.
Hmm.
And when you mix surgery with a distorted reality, the results can just be, well, devastating.
And that contrast is exactly what we're exploring in this deep dive today. Our mission is to really unpack this incredibly complex intersection of genital aesthetic surgery and psychology.
Yeah, it's a fascinating area.
It really is. We want to figure out how clinicians actually identify when a patient's, repetitive or excessive requests for genital alterations are actually driven by body dysmorphic disorder, or BDD.
Right, because it's not always obvious.
Exactly. And to do this, we're pulling from a massive stack of sources today. We've got clinical guidelines from organizations like the National Institute for Health and Care Excellence, or NICE. We're looking at standardized psychiatric screening tools and some truly fascinating brand new data from a national survey of Australian plastic surgeons.
Oh, that data is wild.
It is. They're actively navigating these newly mandated screening laws, and we'll get into how messy that real-world friction actually is.
Yeah, I think before we can even look at how doctors test for BDD, though, we really have to establish what they're actually looking for.
Right.
Because in pop culture, the term body dysmorphia gets thrown around so casually, like it's used to just mean feeling insecure about your body or having low self-esteem.
Yeah, like someone looking in the mirror and wishing their nose was a little smaller, or,
Yeah.
wanting to lose 5 pounds.
Exactly. But looking at the diagnostic criteria from the DSM-5 and the ICD-11, which are the global gold standards for psychiatry, BDD is classified as an obsessive-compulsive spectrum disorder. It's not just vanity. It involves a really severe, highly distressing preoccupation with a perceived or slight physical defect.
And the crucial distinction here, based on what I was reading, is that this defect is something that other people barely notice, or they literally cannot see it at all.
That's the key.
Yeah.
It is a profound distortion of reality. The patient looks in the mirror and sees this glaring, grotesque deformity where a surgeon just sees, normal, healthy anatomy.
Wow.
And the psychological toll of carrying that distortion around every single day is massive. BDD is frequently comorbid with major depressive disorder. When you look at the clinical literature, we're talking about up to a 46% rate of suicidal ideation.
Oh my gosh.
Yeah, and an 18% rate of actual suicide attempts among these patients.
18%. Wait, that takes this entirely out of the realm of vanity.
Completely.
That places it firmly in the category of a life-threatening psychiatric condition.
It does. It really does. And, in the general population, BDD affects roughly 1 to 3% of people.
Okay.
But the prevalence problem becomes really apparent the second you step into an aesthetic setting. Those numbers just spike dramatically. In general plastic surgery, the prevalence jumps to around 15%.
Right, and I was looking at one specific study in our research stack that focused purely on genital aesthetics, specifically women seeking labiaplasty.
Yeah, that's a very telling study.
It really is. Out of 55 women evaluated, 10 of them met the strict diagnostic criteria for BDD.
Wow.
That is nearly 1 in 5 patients walking through the clinic doors for that specific procedure.
Yeah, which is a huge proportion.
It is. Which brings up the obvious question, I guess. If it bothers them that much, why not just do the surgery? Wouldn't fixing the physical issue alleviate the psychological pain?
You would think so, right? But that is the ultimate trap of BDD, and it's exactly why it is universally considered a major contraindication for surgery.
Okay, why is that?
Well, operating on patients with severe BDD usually leads to incredibly poor postoperative satisfaction. The surgery doesn't address the root cause,
Right.
so the underlying psychological distress just remains untouched.
It's kind of like, it's like trying to fix a software glitch by swapping out your computer monitor.
Oh, that's a great analogy.
Yeah, like you can buy a bigger screen, a higher resolution screen, you can change the hardware all you want, but the code running in the background is still generating the exact same error message. You haven't touched the actual bug.
Exactly. The scalpel cannot rewrite the code. So what happens clinically is that the patient's obsession simply migrates.
They find a new flaw.
Precisely. They might shift their hyperfocus to a new problem area on their body, or they become completely fixated on the surgical outcome not being absolutely perfect.
Which leads to more surgery, I assume.
Endless revision surgeries.
Yeah.
And from a professional standpoint, it becomes a massive medical legal risk for the surgeon.
Mhm.
But from a patient standpoint, it's just a tragic continuation of their suffering.
So if the stakes are this high and the prevalence in these specific clinics is this concentrated, how does a clinician actually spot this software glitch during a standard surgical consultation?
It's tough.
Because I have a bit of pushback here. You've got a plastic surgeon who has spent, what, a decade training in anatomy, tissue dynamics, surgical technique.
Yeah, they're surgeons, not therapists.
Right. How are they supposed to suddenly pivot and play the role of a seasoned psychiatrist during a 45-minute consultation?
Well, the short answer is they aren't.
Uh,
They aren't expected to make a formal, ironclad psychiatric diagnosis.
okay.
What they're expected to do is perform risk stratification by spotting behavioral red flags.
Got it. Like what?
There are highly observable warning signs in the consult room if a surgeon knows what to look for. For instance, these patients don't just point out a flaw. They might bring in a folder of multiple photographs, heavily focusing on specific angles or weird lighting.
Oh, to prove the existence of the defect.
Exactly, to prove a defect that the surgeon can barely even see.
The language they use also stood out in the literature we read.
Oh, definitely.
They use incredibly harsh, disproportionately negative language to describe their own anatomy. It goes way beyond typical insecurity.
Yes, a very visceral self-disgust. You also look for a history of multiple unsatisfactory procedures.
The shopping around.
Right, the classic shopping around behavior. They've been to 3 other surgeons, had the procedure done twice, and are still deeply unhappy with the result.
That makes sense.
And in the clinic itself, they might display repetitive physical behaviors, like constant mirror checking. Or they'll talk about the intense, exhausting efforts they go to in order to conceal the perceived flaw in their daily lives.
So it's actively disrupting their day.
Yes. Add invisible signs of severe anxiety or depression during the consultation, and the picture starts to become pretty clear.
But relying purely on a surgeon's intuition or, their ability to read a room, that seems incredibly risky to me.
It is.
Like, if a patient is just really good at masking their anxiety, or if the surgeon is just having a busy, distracted day, patients are going to slip through the cracks. They need an objective toolkit, right? Not just a gut feeling.
And that is exactly where formal screening tools come into play. These are scientifically validated questionnaires designed specifically to catch these behavioral patterns.
Okay.
They turn subjective feelings into objective data. The most prominent one in the field is the BDDQ, the Body Dysmorphic Disorder questionnaire.
Right, and the genius of the BDDQ, from what I saw, is that it breaks the condition down into scored, quantifiable metrics.
It does.
It doesn't just ask a vague question like, are you worried about your appearance? It asks specific, time-bound questions. For example, it asks if the patient spends more than 1 hour a day obsessing over the specific defect.
Which creates a measurable threshold. It also asks whether this preoccupation actively interferes with their daily life.
It's like avoiding social events.
Yeah. Are they avoiding social events?
Yeah.
Is it impacting their occupational functioning? Is it destroying their intimate relationships? These tools force the patient to actually quantify their distress.
And they even have modified versions just for genital procedures, right?
They do.
There's the COP-PSL, which is the Cosmetic Procedures Screening Questionnaire, modified specifically for labiaplasty, and the GAS, the Genital Appearance Satisfaction Scale.
Yes.
They basically swap out general questions about your appearance for highly specific anatomical concerns. And the protocol here, according to guidelines from groups like NICE, is that if a patient flags positive on these tools, the surgeon shouldn't just, slam the door and turn them away.
Right, because turning them away just sends them to another potentially less scrupulous surgeon down the street.
Yeah, that doesn't help anyone.
No. The medical obligation is to refer that patient to a mental health professional. The goal is to route the patient to the psychiatric care. They actually need things like cognitive behavioral therapy, CBT, or SSRI medication.
Instead of just providing a surgical intervention that will likely harm them.
Exactly.
Okay, so if these questionnaires work so well in a vacuum, you take the test, you find the glitch, you reroute the treatment, what happens when a government actually forces surgeons to use them in the real world?
Well, this is where it gets really complicated.
Because in 2023, Australia tried exactly that.
Yeah. Australia provides this incredible real-time case study in medical regulation. The Australian Health Practitioner Regulation Agency, AHPRA, They enacted this sweeping mandate requiring validated psychological screening for all cosmetic surgery patients.
Every single one.
Every single patient. Regardless of the procedure, they had to be systematically screened to identify BDD before they ever reached the operating room.
I mean, it sounds like a massive win for patient safety on paper.
On paper, yes.
But we have data from a national survey conducted in October 2024 asking Australian aesthetic plastic surgeons about their, on-the-ground experience with this mandate, and the results are completely baffling.
They really are.
Because remember earlier we established that the literature suggests up to 15% of cosmetic patients might have BDD.
Right, it's a highly concentrated, high-risk population.
So despite that established prevalence, 70% of the Australian surgeons surveyed reported diagnosing 0 cases of BDD in the past year. 0.
It's astounding.
Furthermore, 84% of them referred less than 5% of their total patients for a psychological assessment.
It completely contradicts the expected statistical models.
Yeah.
And when you dig into the mechanics of that survey, you uncover this incredible friction between the clinicians and the mandate. The surgeons expressed remarkably low confidence in these mandatory tools.
So low.
They rated them, on average, a 3.2 out of 10 for both accuracy and usefulness.
Wow. A 3.2 out of 10 is a failing grade by any metric.
Pretty much.
It shows they view the paperwork as just a bureaucratic hurdle, not a medical asset.
And it also comes with a tangible operational cost. Administering, reviewing, and documenting these screenings adds about 11.6 minutes to an average consultation.
That's a lot of time in a clinical setting.
It really is. Picture the clinical reality here. The surgeon is running behind schedule. The patient is sitting in a paper gown feeling awkward holding an iPad, and they are both forced to go through this mental health checklist that neither of them fully believes in.
Right.
So it's no surprise that only 30% of surgeons said they would continue using these screening tools if they weren't legally mandatory.
It's just wild. Why is there such a massive disconnect between the clinical theory and the clinical reality?
What do you think?
Well, I think it comes down to the fundamental flaw of relying on self-reported questionnaires in a high-stakes environment. It is exactly like taking a personality test when you're trying to land a competitive corporate job.
Oh, that is so true.
Right. Like, if you know that answering honestly, saying you prefer working alone and you hate teamwork, if you know that means you don't get the job, you are simply going to lie.
Of course you are.
You just check the box that says you are a team player.
Human behavior will always try to bypass a rigid system if the incentive is high enough. And for someone with BDD, the compulsion to fix their perceived flaw is an overwhelming, all-consuming incentive.
They know the job they're applying for is the surgery they desperately want.
Exactly. So if they admit on that iPad that they spend 3 hours a day crying in front of a mirror, they know the surgeon is going to reject them and send them to a psychiatrist.
So they just underreport their symptoms.
They check the box that says they only think about it for 15 minutes a day.
And the sources even noted that patients actively swap advice in online forums.
Oh, yeah, they do.
They coach each other on exactly how to answer the questions to, quote-unquote, pass the test and secure a surgery date.
Which raises a critical dilemma. If the screening tests are this easily gamed by highly motivated patients, and the surgeons are deeply skeptical of their utility, where does that leave the diagnostic process?
It's a mess.
It forces us to ask a very controversial question. Is a positive BDD screen an absolute hard stop for surgery in every single case?
Like, can the surgery ever actually fix the psychological distress?
Well, if you look at the strictest medical views, like the guidelines from the Society of Obstetricians and Gynecologists, so joke, they take a very conservative approach.
Okay.
They strongly recommend that genital procedures be reserved primarily for clinical manifestations.
Meaning physical issues.
Right, things like morphological abnormalities or physical trauma, rather than purely subjective aesthetic desires. Their emphasis is heavily on educating the patient about the wide range of normal genital diversity.
So trying to foster self-acceptance rather than resorting to surgical intervention.
Exactly.
Which is a very safe foundational approach rooted in, do no harm.
Right.
But this is where the research that completely blew my mind. Let's talk about the Goodman study, because it challenges everything we just established about that software glitch analogy.
Yes. The Goodman study is a fascinating piece of counter-evidence. So the researchers looked at a group of women actively seeking genital plastic surgery. Before the surgery, they administered those strict, standardized psychological tests we were just talking about.
And what did they find?
A staggering 61% of these women met the psychological criteria for body dysmorphic disorder.
61%. By the strict guidelines we just discussed, you would cancel all of those surgeries immediately.
Yep. You would refer them all to psychiatry.
But they didn't.
No, the surgeons proceeded with the operations. And here is the mechanism of why this study is so important. At the 6-month post-operative mark, they retested those exact same women.
Okay.
Their BDD scores had plummeted from over 60% down to just over 8%.
That is a massive, statistically significant remission rate.
It's huge. Their post-op BDD scores were actually lower than the control group of women who hadn't sought surgery at all.
Which suggests the scalpel actually did rewrite the code for them. Like, the surgery cured the psychological symptoms.
It seems that way.
How is that possible if BDD is a psychiatric disorder?
It proves that BDD is not a monolithic condition. It exists on a highly nuanced spectrum.
Okay, a spectrum.
Right. Severe BDD, where the patient is completely delusional about a non-existent flaw, severely depressed, and totally non-functioning, that remains a clear and absolute contraindication for surgery.
The surgery will fail for them.
It will fail. But the literature suggests that patients with mild to moderate BDD, people whose daily functioning isn't severely impaired, but who are still highly distressed, they might actually benefit from aesthetic surgery.
Really?
Especially if they are concurrently supported by a mental health practitioner who can help them process the physical changes.
See, this perfectly highlights why clinical judgment has to override a rigid bureaucratic checklist.
Absolutely.
Like, consider a real-world scenario, a postmenopausal woman who has experienced distinct natural physical changes over time, perhaps after multiple childbirths or hormonal shifts.
Right, very common.
She goes into a clinic highly distressed because her body has changed in ways that make her deeply uncomfortable and affect her daily quality of life.
And if you give her a rigid BDD questionnaire, she might flag positive simply because her distress is currently very high and she thinks about the issue every single day.
A rigid system, like that Australian mandate, would reject her. It would label her with a psychiatric disorder, deny her the procedure, and send her away.
Just based on a score.
Exactly. But a skilled surgeon, using nuanced clinical judgment, might recognize that her physical concerns are valid, her expectations for the surgery are realistic, and her distress is proportionate to the physical changes.
She might be an excellent, highly satisfied candidate for the procedure.
Right. The checklist lacks context, and context is, well, it's the most critical component of medicine. You cannot distill a patient's entire psychological landscape into a score out of 10.
No, you can't.
So the overarching takeaway here is that screening for body dysmorphic disorder in genital aesthetics is incredibly vital, but it's a deeply flawed process in its current state.
Yeah, that's a fair summary.
We have scientifically validated tools like the BDDQ and the COPSL, which are great in theory, but the real-world data from Australia proves that when you force a mandate, it just struggles against the messy realities of human response bias and clinician skepticism.
Patients will lie on paper to get the surgery they desperately want.
And doctors resent spending 12 minutes on a form they know is being gamed.
Exactly. And whether you are a clinician trying to optimize how you screen your patients, or someone personally considering a cosmetic procedure, or just a curious learner interested in limits of human psychology, this scenario really highlights the danger of relying purely on checklists in medicine. It proves that understanding the why behind a patient's decision is just as critical as the what. You simply cannot separate the human mind from the human body.
You really can't. But, knowing that humans are inherently flawed, knowing that patients lie on questionnaires, and knowing that surgeons can be rushed, biased, or even have their empathy weaponized by a distressed patient sitting in front of them, it leaves us with a really provocative thought based on all this.
Oh, I'm intrigued. What is it?
If the human brain has a software glitch, and the human surgeon is too biased to see it, do we need an algorithm to debug the situation? Like, could artificial intelligence be the solution?
Wow. It's a fascinating, albeit controversial, frontier.
Imagine an AI system integrated into the consultation room. It's trained to objectively analyze the microexpressions, the subtle vocal tones, and the specific language patterns in the doctor-patient interaction.
Right.
It could automatically flag the harsh self-criticism or the obsessive repetition, removing human bias and time constraints entirely. And it couldn't be gamed by a patient who read a forum post because it's reading involuntary physical reactions and conversational cadence, not just, multiple-choice checkboxes.
I mean, it would certainly solve the subjectivity problem and the issue of self-reported lies.
Right.
But it opens an entirely new Pandora's box of questions regarding patient autonomy. Would we be comfortable handing over that level of intimate psychiatric evaluation to an algorithm?
It's a heavy question.
Would we trust a machine over a human being to tell us if our deeply personal desire to change our own bodies is a valid choice or a psychological disorder?
We started this deep dive talking about how much we crave the clarity of an X-ray.
Yeah.
It seems like even with all our standardized questionnaires, government mandates, and maybe even future AI algorithms, when it comes to the human mind, we're always going to be navigating the murky
They
waters.
really are.
Let that sink in next time you look in the mirror.